Thank you all for coming to the AI and radiology session. We have some great speakers here for you today. One housekeeping item I'd like to note is that on the top of the video that you're watching, you'll see an Engage tab. If you click over there, that's where you can type your questions for our speakers. The chat feature on the far right side, that's more for networking amongst each other and yourselves. But if you have questions directly for the speakers, definitely put them in the Engage tab. So without further ado, I'll pass it off to our moderator, Dr. Vasanawala, and thank you all.
Thank you so much, Mary, and thanks to everyone who has joined this session. I hope everyone is enjoying the conference overall. This is a session on current technology and future directions. I'm Shreyas Vasanawala. I'm a professor of radiology at Stanford University. We have three outstanding speakers for today's session. One is Ali Syed, who's a faculty member in radiology at Stanford as well. The second is Evan Zucker, who is on faculty at the Massachusetts General Hospital and Harvard Medical School. And the third is Sergius Gatidis, who's at the Max Planck Institute for Intelligent Systems. Each of these talks that you will see is right at the cusp of clinical translation, taking science right into the clinic and benefiting patients. You'll see that these talks also cover the breadth of imaging. As you know, most of the excitement and sort of lay press around the applications of artificial intelligence in medical imaging or in radiology tends to focus on actual interpretive tasks. How are images analyzed and how does that lead to specific diagnoses? But you'll see in these talks that there's actually a much broader range of applications for artificial intelligence in the field of radiology. And so you'll see one talk is focused on how to ensure that there's good image quality and how do you actually prescribe the images on the imaging equipment. Another talk will be on how images can actually get reconstructed from the raw data that the hardware in these imaging systems acquires. And then the third is on how to process these images in terms of segmentation. Another aspect of this session that you'll see is that we're going to focus on an underserved community in the field of AI, and that is children. This session has been organized by the Stanford Pediatric Radiology Innovation and Translation Center, and so it's quite appropriate that you'll see all of these talks heavily focusing on children and their healthcare. And you will also see the final talk of this session by Sergius Gatidis will highlight why that dedicated focus on pediatrics is clinical. So without further ado, I'd like to introduce our first speaker, who is Ali Syed, again, a professor of radiology at Stanford University. Okay, Ali, the floor is yours.
Thanks so much, Shreyas. Okay, so as Shreyas mentioned, I'm a assistant professor of radiology here at Stanford, and I also serve as the director of MRI for Stanford Children's. And I'm going to be talking about enabling robust MRI with artificial intelligence, and in particular, really focusing on image acquisition. How do we make sure that we're getting good images to start with? MRI, as you know, both people inside and outside of healthcare know, is a really powerful and very flexible diagnostic modality with really excellent soft tissue contrast. And you know, when we think about X-ray, CT, ultrasound, all the tools and MRI, all the tools available to us, you know, MRI really is kind of the newest tool, but it's also one of the most powerful and one of the most flexible. It gives us really excellent soft tissue contrast, and really, if you think about it, just about any body part that you could fit in a scanner, right? Whether it's your head, your wrist, your foot, your abdomen, it all is often evaluated with MRI. It also has no ionizing radiation, which is really important, particularly in our pediatric population. That being said, those of you that have had an MRI know that it's not a trivial thing to go through. These exams can be 30, 40 minutes, sometimes an hour or more. You have to lay in a cold room on an uncomfortable table. It's usually a pretty small bore. It brings out people's claustrophobia. And so despite the fact that we know that MRI is so great, it's actually still kind of underutilized because of all these factors. And the last point about this is that actually it's quite complex to scan as well. As much as we'd love to think that, we can just put somebody on a table, move them inside and hit scan the knee, it's actually not that simple at all. And as I'll show you in a second, there's actually quite a large number of parameters for technologists to adjust on a per patient basis. This is really exacerbated in the case of pediatrics, where you may be imaging, anything from a child who was born a few hours ago and you can literally hold them with one hand, to a teenager that is, essentially adult size, both in height and weight. And for us at Stanford Children's, we also care for expectant mothers, so we often are scanning, actual adults. And this wide variation in body parts, in sizes that are being scanned, and then the wide variation of image contrast that we can generate from MRI actually breeds quite a bit of complexity. And so in a way, it's great that MRI is so flexible, but that also engenders some complexity when it comes to actually performing the scanning. And this is just an example of an MR interface from one vendor. Every vendor has their own way of presenting information to you, but I've shown this right with this red box here in the bottom highlighted, really just to make the point that, all of these boxes that are grayed out here with drop-down menus are all parameters that can be adjusted by the technologists, by our scanning personnel. And there's 20 just shown on this page alone, and you can see that there's actually a set of tabs here. In this case, there's 3 tabs, but in many cases there could be 5 or 6 tabs. And so all of a sudden, you're rapidly talking about upwards of 50 parameters that a technologist could potentially change, and often does have to change. And the manipulation of these has a really close interaction with what is the imaging that's coming out. Are the images grainy, noisy? Are they blurry? Did the imaging take too long to acquire and now there's motion? There's all of this interplay that's happening. And at the same time, we are also asking our technologists to monitor the images that are coming up here, but to forge through the exam fast because we need to scan more patients in a day, to also comfort our pediatric patients who are maybe a little bit in an uncomfortable situation. So give them coaching, give them support, and and many other things on top of that, right? Think about screening the next patient that is to be scanned, finish post-processing imaging for the last patient. It's actually quite a hectic environment. And at the same time, we're asking them to make these changes that directly impact the diagnostic ability of our scans. And so what this idea really led to, the understanding that this challenge is there for our technologists, is a development of some software that we kind of conceptually thought of as a smart scanner. Wouldn't it be great if the scanner itself had some tools built into it to really support the technologist to make sure that the images that we're getting are what we want? And this is an example of image acquisition support focused just on signal to noise, right? And so it's a common thing we're worried about in radiology. You can see a noisy image here that's quite grainy, and you can see a much cleaner image here. But I'm going to pose to you this question that is a common refrain in radiology, particularly when you're deciding, what imaging to acquire for a brain in this case and how long to spend doing it, is this idea that how good is good enough. And I think at first glance, I think just about anyone would say, wow, this one in the bottom here looks prettier than the one on top. But it's not quite that simple, right? Let's say the goal of the exam is just to see the ventricles, these bright structures here, and make sure that they're not huge and taking up most of the brain. Well, in that situation, actually, both of these perform the same. And if I were to say this one takes only a minute to acquire and this one takes 8 minutes to acquire, you would say, actually, maybe this one is good enough for that purpose, and I'll use that time to scan another patient or get some additional information. So this idea of how good is good enough is actually quite challenging. It depends, as I just mentioned, on the diagnostic task. right? It also depends on the body part, right? We often get really beautiful imaging of brains, but in the abdomen where things are moving, we struggle to get the same resolution. And then there's also the extremities, and so really there's a lot of variability in what we're acquiring, and how good is good enough is not that straightforward. And again, we mentioned that point about the ventricles, where maybe this one is good enough. At the same time, if we're looking for subtle abnormalities between this darker gray and this lighter gray, between the gray matter and the white matter, well, here we might say, it's actually quite challenging to see, but we may look here and say, oh, actually, this is quite sharp, and this is really what we need. And lastly, I would say, aside from the fact that this is, how good is good enough is dependent on the content and the diagnostic task, I'd also say that, beauty really does lie in the eye of the beholder. And so what's good enough for me may not be good enough for the next radiologist, or at a different practice site, or on a different scanner. I think anyone who's really done any work in this space knows that there's quite a bit of subjectivity. And so when we were thinking about, well, how do we train a model or design a system that will support the technologist to help them understand, okay, they made some changes to the imaging to try to get it done faster, but isn't imaging still good enough? We really had to grapple with all of these things. And the sort of simplest way to do this would be to say, well, I'm the director of MRI, so I'm going to grade a bunch of images as diagnostic and non-diagnostic from an SNR perspective, and that'll be what it is. But again, would I then have to retrain and relabel for every specific anatomy and for all the diagnostic tasks? And the second that this gets translated to another practice, we'd have to start all over again. And so we wanted to approach this in a way that would make this a little bit more flexible and a little bit more portable. And again, I think here, right, it's quite clear which one of these is better. But if I show you another image that actually does have differing noise levels, you may struggle really to see the difference, right? And so again, really getting to this point that there's some subjectivity in this that we all know. But instead of trying to fight this subjectivity, we thought, how do we capture this subjectivity, but do it in a way that is we can still have a meaningful system. And so one of the things that we really came up with was this concept of an image ruler. And I'll show you how we use this in a second. But this is essentially a scale, right, from 0 to 7. So it's essentially an 8-point scale of varying noise levels, right? There's varying degrees of noise, and in fact, varying degrees of perceptual noise as well when evaluated by radiologists. And you can see that quite clearly, right? That this is much noisier image. This is a noisy image that I had just shown you, and this is a clean image that I had just shown you. And from here, it's not that trivial to say, okay, I'm going to train a neural network that's going to essentially do a noise assessment and give a score of how much noise there is. And we can do that, essentially by giving a bunch of different anatomies and different scans of labeled data, and then have a network has this ability to generate a noise assessment score. So then what we do is we have this neural network, and actually, if we're scanning a brain, then we have this standardized image ruler for the brain for this diagnostic task, and then we feed in the entirety of the ruler, and so each point in this ruler will have a score generated by this neural network. So now we essentially have some calibration levels, right? We know kind of what is a raw score for each perceptual noise level here in the ruler, and we can take our clinical image that gets put in as well, and that also has a score that's generated. And from there, we're essentially doing a matching procedure, right? We're trying to match, okay, we're doing the noise assessment of the ruler, a noise assessment of the clinical image that was just scanned, and we're going to match it to see, okay, which one of these images is it most similar to from this noise assessment perspective. And from here, now it's actually quite simple, right? Because I can, as a radiologist, just define a threshold for this diagnostic purpose. And in this case, maybe I say, this protocol, we're looking for this specific abnormality when we're doing this MRI. And so for this sequence, for this set of pictures, I'll take a threshold of 3. And so this would generate a score of 4, and we can say, okay, this is passing. But if we have a different context, right, then I may say, okay, in this context, I want a score of 6 from the imaging ruler, and I don't have to retrain a neural network. I don't have to basically, relabel data for a different anatomy or for a different purpose. All I can basically say is, slide up the threshold in this ruler and say, actually, for this purpose, these really need to be a score of 6 or higher. And in our same sort of example where, we have a clinical image, it comes through, we generate a score of 4, then actually we have a feedback dialog that then pops up on the scanner. And so everything that I'm showing you is actually a software that we have running on scanners at Stanford Children's. And so in this case, where now we have scored lower than the radiologist picked threshold, we actually have a pop-up that comes up and it says, based on our analysis, we don't think that the SNR is efficient. So this pops up to the technologist and they're now forced to interact with this. And they can indicate, I think that you're way off, and we can, of course, collect that and use that for QC purposes. But as is more commonly the case, they look at the images and say, okay, I guess this is not quite right, or yeah, I agree, this isn't quite right. We actually give them suggestions. And so this is an early version where we just sort of had one suggestion. Now we have some additional suggestions about decreasing the acceleration, maybe just increasing the scan time to get better quality images. And the technologist can say, actually, I think that option 1 is a good way to go. And they click this, and this actually propagates within the scanner. So sets up a whole new prescription with the parameter change, and the tech can just hit scan and then see the score of the subsequent image. So this is really one way that we can provide some additional help to the technologist as they're changing these parameters, and we can set these rulers again for different anatomies, for different imaging protocols. So if it's MRI for seizure, we can have this sequence can have 1 score. If it's MRI for a tumor, the sequence can have a different radiologist threshold, and we can do all of this without having to retrain, which is really, really beneficial to us. And again, if you went to a different practice, you could change this based on your preferences there. And I think more importantly, as our imaging quality improves, gets better and better and better, then we can essentially readjust the rulers, and again, not have to go through this whole process of retraining the model. And so this worked so well that we said, okay, well, maybe we should try to tackle artifacts of other kinds. And so we decided to approach this with a multitask model. So this model now has sort of shared layers, and then a branch that does the noise assessment that we just talked about. And then we also went on to look at rigid motion artifacts. So here you can see some motion, which is sort of linear lines here, and we can assign a score much in the same way. And look at rigid motion. And then we've now expanded it to even an additional branch with it, which is a peristaltic motion. So as rigid motion often presents as the sort of rigid lines that we saw, the sort of discrete lines that we saw in the previous example. But peristalsis, which is the motion of your bowels to help move things through, it's actually a little bit more nefarious, right? Because if you look at this image and you look at this image up top, you would say, they look pretty similar. Although if you look at the zoomed up image, I can show you here, this is an image of a rectum. You can see each layer of the bowel quite nicely, right? You can see the dark layer, that bright layer in between, then a dark layer again. And it turns out that seeing each one of these layers is actually critical to staging rectal cancer appropriately, which is now done by MRI. And if you get the stage wrong, it can actually have really catastrophic implications for the patients. And seeing each one of these layers is actually quite important. So now, if you compare this to the zoomed up version, you would say, hopefully you can appreciate, there's quite a bit of blurring here. This is actually quite challenging to see all the different layers. But again, as a technologist, particularly if you're an inexperienced technologist, maybe you haven't scanned that many cases for rectal cancer because they only come along once in a while, you can understand how actually picking up on it when you're just looking at these images while trying to manage everything else in a clinical environment could be quite challenging. And so this is from all of this work. I just want to highlight this paper here from one of our really great graduate students, Lisa Lay, who put in the hard work to do a lot of this stuff. And this is just some of the results of our model looking at standard motion, rigid motion, peristaltic motion, looking at noise, both, and then also on images that are really out of distribution. And you can see our multitask model performs better in almost all situations. And also you can see that we have scoring here that's comparable to radiologists in terms of accuracy. And so So this is our sort of newest implementation that we have starting imminently here on the adult side in Stanford, which is for these patients that get rectal cancer. They'll essentially, they get the imaging done, and then it gets fed through the multitask model, and the peristalsis motion assessment is done as sort of a green light, yellow light, red light. And so the green light basically means there's no motion, you're doing great, go ahead and scan. The yellow light means there's some subtle motion there, it's not quite good enough, but we have some motion mitigating sequences that you can run. So, use this technique, and we actually give the feedback to the technologist, hey, you need to use this technique instead, try and eliminate this motion artifact. And then there's the red light, which is, hey, there's a ton of motion here, this is really bad. And this actually triggers a phone call to a radiologist. So the technologist can say, can you take a look at this? What do we need to do? And in that case, we may actually give a drug to try and eliminate the peristalsis, or redose a drug to try and eliminate the peristalsis. And so again, what this is really doing is, preventing the technologist from having to call us every single time to check what's going on, which of course really results in radiologist interruptions, but also still having the ability to really do this quality monitoring for the technologist, really regardless of their experience. In the last couple of minutes here, I just want to shift gears a little bit. I've been talking sort of, okay, after the imaging is acquired, as soon as the image is reconstructed, how do we verify that it is what we want it to be? But we can even shift upstream a little bit more and focus on how to get the images correctly up front. And one of the ways that I'll highlight here is in cardiac MRI. And so actually, traditionally, cardiac MRI is not performed by standard MR scanning technologists. There's special training. And that's because there are some nuances. And one of the big things that instead of just scanning sort of typical axial, coronal, sagittal planes, we have these sort of heart-specific type of planes here. And so you can see, if we want a nice overview of the heart, like this 4-chamber view here, actually we have to scan an axial, and then we have to scan this plane, then we have to scan this plane, we have to get this one, and we have to cut it along this red line to get this. But realize in 2022, this is actually a relatively straightforward computer vision task, right? To find these planes in a normal heart. And along with some collaborators in industry and at UC San Diego, a model was developed that essentially, is able to generate these planes based off some landmarks while looking at the anatomy. And this is now, again, directly integrated into the scanner. So this is something that our scanning technologists can use. It's great because it reduces variability between technologists. Some people have been trained slightly differently on what landmarks to use, and it really reduces the variability. This is instantaneous, so it reduces the time necessary. Instead of a tech fiddling around with the interface to make the plane, it just pops right up. And again, it reduces the cognitive load, right? We said technologists have all these things that they have to pay attention to, and this really helps us get through the exam a lot faster. And when you couple, the speed of doing something like this with some of the new technology that Dr. Zucker is going to talk about, you're all of a sudden talking about doing an MRI, cardiac MRI that used to take 45 minutes is now something you can do in less than 10 minutes, which is quite game changing. Here's just an example of this system running on a patient, the patient being yours truly. And you can see here that these blue lines are essentially just going to pop up entirely on their own. And all of these planes are being selected by the scanner completely on its own, actually. And just showing, how robust this actually is. And again, we do have this running in the clinic, working for us every single day. So just going to wrap up here and say that, again, we know that MRI is a powerful diagnostic tool, and, but it does have this really significant complexity. But hopefully I've shown that with some, foresight, we can actually incorporate some AI tools using some machine learning into the scanner itself to help us get better images up front. And I think in the future, what we'll really have is, not just analyzing the image, but even mining the EMR, the patient biometric data, to know upfront what the scan strategy should be. And then with that, we'll really have MRI of the future. I'm not sure if it'll quite look like this. I typed smart MRI scanner from the future into a stable diffusion instance and got a picture like this. So I'm not sure if that's exactly what we're going to get in the future, but hopefully it's going to be better than what we have, and we're already starting to see that with our implementation so far. So thanks so much to everyone at Amy at Stanford, our collaborators, and particular shout out to our graduate student, Lisa Lay, who did a lot of the seminal work in this space. Thanks so much.
Great. Well, thank you so much, Dr. Syed. That was a wonderful presentation there. There's a few questions that have popped up. One of them is that what is the future of a dedicated neonatal MRI scanners? And depending upon where sited, who will push the buttons?
Yeah, I think that is a really great question. You know, particularly these low field scanners we're starting to see really explode in popularity. And I think that they probably are here to stay. I think who will operate them is a really significant challenge. And I think, you know, we're making headway to make these things easier to use, but I think as currently constructed, you know, they probably still are the domain of trained MR technologists. But I think I can particularly imagine for cases like a stroke or a hemorrhage where, you know, we maybe can get them to the simplicity that, you know, less personnel with less expertise can position the patient and then go on their way.
Great. And then one other question that's come in says, how does the ruler, quote unquote, ruler take into account FDA regulations on power deposition and SAR?
So the ruler is basically just varying noise levels, you know, noise assessment of varying degrees. And so, you know, whether you want to invest the scan time, which is intimately linked to the SAR and the power deposition to acquire those images, is I think not something that has been addressed by the ruler directly. And I think the point is well taken that you may easily say that, you know, oh, to get a score of 7 is actually prohibitive in a clinical context because the SAR deposition would be so high that we'd have to drag the TRs out. And now, you know, it's going to take 40 minutes to acquire. The rulers are generated in a standardized fashion to fall within kind of diagnostically relevant ways. And if you look at the paper, we actually have quite a bit of detail about how the rulers are generated in the paper. But I think that, you know, it's true, the devil is in the details, and how you identify that ruler and how you construct those rulers actually, you know, the whole thing hinges on that. So.
Great. Well, thank you very much. I think we'll now move from the West Coast of the United States to the East Coast of the United States and to Dr. Zucker. Evan.
Yeah, thanks for the introduction, Shreyas. The title of my talk is Faster and Better, Improving Cardiac MRI Image Reconstruction Using AI. And although I'll be mainly talking about cardiac MRI in children, these principles are really applicable to all sorts of imaging modalities and applications. And I'll also just mention that the majority of this work was done at Stanford and much of it pioneered in Shreyas's lab. Disclosures are listed here. So as Dr. Syed already talked about, pediatric or cardiac MRI in children, you know, can be a wonderful modality. It can evaluate ventricular function, ventricular volumes, flow, get a sense of the anatomy. However, it can be often, you know, difficult. This is an ideal situation, a snapshot from the PET-MR scanner at Stanford Children's, showing, you know, patient wearing video goggles and having a nice experience in a kid-friendly environment. But as Dr. Syed already alluded to, cardiac MRI presents a number of challenges in children. The acquisition complexity, which AI can help with, and Dr. Syed already talked a bit about that. And then, you know, the exams tend to be long and require multiple breath holds in order to get adequate image quality. In this talk, I'll be focusing on the reconstruction aspect and how AI can help us with this to get better image quality without necessarily sacrificing anything. And in Sergios's talk, he'll be focusing more on post-processing applications of AI. So, you know, there's some classic trade-offs in MRI between signal to noise ratio, resolution, and speed. And, you know, overall, essentially, if you want better image quality, usually you have to do a longer acquisition. You can tweak other parameters, of course, but, you know, that's inherently challenging in children who can't sit still and you know, in a busy practice, you know, you only have so much time to scan these patients. So kind of the basic principle of how we can use AI to enhance image reconstruction with MRI is basically essentially to undersample case space and then use AI methods either in the image domain or case-based domain to reconstruct images of, if not identical, very similar quality to the reference images. So I'll talk about a few different applications of AI in cardiac MRI in children. We'll focus a lot on cine imaging and then talk about some other applications as well. So, as Dr. Syed already alluded to, kind of the workhorse sequence of cardiac MRI in children or adults for that matter is cine bright blood imaging, often done with a balanced steady state free precession sequence. And you can see, the heart pumping in various planes here. And then we also typically obtain, what's called a short axis stack, which is basically a cross section through the ventricles. And, at minimum, usually in a cardiac MRI, you'll want to get enough short axis slices to calculate ventricular volumes and function. So essentially you kind of march along, the heart as if it were, a loaf of bread and get a bunch of different slices. Here you can see they've gone into the atrium a little bit, so maybe could have eliminated some slices, but essentially they needed 16 separate cine slices in order to cover the whole heart. And, with traditional methods, you might get, 2 slices per breath hold if you're lucky, maybe 1 or 2. So, even just doing this can be quite difficult in children. This was one study looking at an abbreviated cardiac MRI protocol. This is out of the Stanford Children's Group in Duchenne's patients and comparing it to echo. And using traditional methods, it took about 24 minutes to do essentially just a short axis stack. So it seems pretty minimal, but took a long time just for that under the best of circumstances. So researchers, have looked at ways to, how we can, basically different ways of undersampling case space and then reconstructing it with high fidelity at similar image quality. So, compressed sensing, was the rage and sort of is increasingly incorporated into some vendor supplied sequences, also low rank reconstruction. And these kind of exploit the sparsicity principle of case space acquisition, where some of the data essentially is more high yield, and some of it you can sort of not use as much and still get a good image. And this requires a lot of complex computational power and processing to do this, although vendors are increasingly incorporating this. This was a nice study out of the Cincinnati Children's Group, just comparing conventional cine imaging. This is on a Philips scanner, breath held and free breathing using compressed sensing. And with the compressed sensing technique, there's some more artifacts, but again, in keeping with what Dr. Syed was talking about, this is probably adequate for, assessing ventricular volumes. Maybe if you needed to look at the myocardium, it's not quite good enough. There's too much artifact. So how can we use AI techniques? These are a couple papers that came out of Shreyas's group. This is one paper describing the principle, and another kind of validation study that I led. And basically, in the Stanford Children's, among many others, deep learning models for cine imaging, essentially the inputs to the model are the case-based data as well as coil sensitivity networks. And essentially through a convolutional neural network, the model adjusts the weights of this spirit reconstruction technique, which was also developed at Stanford in collaboration with Berkeley. And this is an auto-calibrating parallel MRI technique. Now, interestingly, this network was trained only on a very small cohort of about 10 to 15 adult fully sampled cardiac cine data sets. But because it functions in the case-based domain and is based on kind of physical principles rather than the actual images, we found it to be quite robust. So these are some data from the validation study that I mentioned. We prospectively recruited 50 patients to undergo traditional cine imaging along with the deep learning cine, which was basically a 12-fold accelerated cardiac cine sequence with the deep learning reconstruction subsequently performed. And this is a very wide mix of patients with almost half of them having congenital heart disease, most done at 1.5T. These are primarily breath held scans for the cine, traditional cine, although the deep learning cine was done free breathing. These are just some side-by-side examples from our cohort. You can see the traditional images on the left and the deep learning images on the right. And although they look a little bit different, and there's maybe slightly less detail and artifacts, two radiologists rated them fairly comparably in terms of overall image quality, and you could debate individual features. But most importantly, the acquisition time was 3 times shorter for the deep learning cine. And when accounting for all the coaching and breath holding instructions, the deep learning cine was almost 5 times shorter than, or more than 5 times shorter than the traditional cine. So as I mentioned, this was trained on adult normal heart patients, but because it worked in the case-based domain, we found it actually performed well, even in unusual anatomy like this single ventricle case. Another benefit that you get using this technique is essentially with any kind of breath holding sequences, there'll be some slice misregistration between breath holds, whereas with this free breathing deep learning approach, you get kind of a more smooth volume. Now the images are fairly comparable, but kind of the most important thing for the patient is that the volumetric data it is consistent. It's you don't want to get images that don't give you the kind of quantitative information you need. So we also looked at the various volume and mass parameters that we typically measure, and 2 radiologists measured those with the traditional images along with the deep learning images. And indeed, there was a high interclass correlation coefficient suggesting concordance between the 2 ways of measuring it. And we also did some Bland-Altman analysis, and there was essentially 0 mean difference for the measurements between the 2 techniques. So again, supporting that this technique is reliable. So in addition to shortening acquisitions, you can also use AI techniques to produce improved image quality in the same amount of time, or even in less time in some instances. This was a nice paper from Albert Shao at UCSD, who was one of Shreyas's former trainees, and you can see in this paper, basically he downsampled the matrix size of cardiac cine images, and then using deep learning techniques was able to reconstruct images of nearly identical to the reference images before the downsampling. But you could see that you might be able to delineate structures that we haven't been able to see well before using deep learning, like valves or other structures. Another focus that the Stanford group has been looking at is using deep learning to improve radial cardiac cine imaging. Traditional MRI is done by a Cartesian or rectilinear sampling of case space, but it turns out that radial acquisitions have been available for a long time, and they tend to have less motion degradation as well as fewer artifacts. but they can be cumbersome to work with because usually you have to use a gridding algorithm to transform them into a rectilinear format so that they can work with fast Fourier transform techniques. So the Stanford group has also been looking at using deep learning methods to improve radial cine reconstructions, as I mentioned. I won't go into a ton of detail, but again, these are the raw radial acquisitions, again, using kind of the spirit calibration approach. And just to show you some images, this is the reference images with the gridding algorithm applied, again, to transform it essentially into a rectilinear case space. You see there's a lot of artifacts, and then with various iterations of the convolutional neural network, various proposals, you get very close to the fully sampled reference images. And if you didn't have deep learning, essentially the state of the art is parallel imaging with compressed sensing. If you want to shorten your or improve your reconstructions. So this is some with parallel imaging and compressed sensing applied. With some of these, you see like quite a lot of artifacts still, but with the final current iteration of the deep learning model, you're able to reconstruct this at least as good or maybe better than the compressed sensing approach. So the next thing I'll talk about is myocardial tissue characterization. And really there, I'm just going to focus on late gadolinium enhancement imaging, which is kind of the cornerstone of myocardial tissue characterization. So basically you give a gadolinium-based agent and then wait, usually at least 8 minutes and give an inversion pulse to essentially null the myocardium. And then using, either a gradient echo sequence or other approaches, you basically, again, image the heart in similar planes as the cine imaging, and you're looking for areas of bright signal that correspond to scar fibrosis. And you can see even in these, this teenager, there's quite a lot of artifact, and we might be thinking, is this real enhancement or not? And it's kind of a judgment call. So this was a nice paper that came out in European Radiology. This was an adult cohort in which they compared standard late gadolinium enhancement to a now commercially available deep learning based reconstruction with various settings of different noise reduction levels ranging from 25 to 100%. So, it takes a little bit getting used to how the images look, and, perhaps like you might think this has a little bit less overall detail or a little more plasticky, but, in terms of the late gadolinium enhancement, we see that quite a bit better as we, reduce the noise. And you get this for free. It's done after the scan was performed. And if you could tolerate less noise, you could shorten your acquisition as well. So, we did have this in use at our scanners at Stanford Children's, or at least some of them with the latest software package. This was like a 9-year-old male who had COVID-19, just to rule out late gadolinium enhancement. And you can see that with the conventional images, they're tolerable, but there's like a fair amount of noise. And then just with this deep learning based reconstruction, again, from a vendor, cleans up the image quality quite a bit. It turns out this vendor reconstruction algorithm, and again, there's many different vendors, can be used on a wide variety of applications. These are just some examples from them directly where, you see better delineation of edema within the spinal cord and cartilage within the elbow. So again, this is like essentially one type of reconstruction that works on a variety of applications. And although it's a bit of a black box, it sort of shows how robust this can be. Then I'll talk about 2D phase contrast imaging. As I mentioned, we can also measure flow. That's using cardiac MRI. That's often necessary for congenital or valvular heart disease. But again, this is a time-consuming process. You have to localize the vessel and do your 2D phase contrast orthogonal to the vessel of interest. This is the aortic valve. We see blood, black blood essentially is going from the foot to the head, and white blood is going from the head to the foot. And, you know, again, these might take at least a 10-second breath hold each, and you have to localize the plane. So again, quite challenging. Shreyas's group has also used deep learning methods along with Dan Ennis at the Palo Alto VA to accelerate these types of sequences as well, both using one deep learning approach as well as a modified deep learning approach with complex difference estimation. And just suffice to say, we got very nice results with that as well. This is, you know, the reference images. This is 9 times accelerated images with parallel imaging and compressed sensing. And then deep learning, at least actually performed a little bit better than the compressed sensing and very close to the reference images. This was also recently published with Shreyas and Dr. Syed and magnetic resonance imaging in medicine, showing that not only was the image quality comparable between these techniques, but also the measurements in terms of velocities and flow are quite comparable as well. The final thing I'll talk about is 4D flow, which I think has still a lot of active potential for deep learning to be more robust. So as we talked about earlier, 2D phase contrast, essentially you localize the vessel and get one slice orthogonal to it and measure the flow in that plane. But with 4D flow, we can essentially measure flow in all 3 directions at the same time, as well as the anatomy using a volumetric acquisition. And from there, we can, you know, reconstruct in any plane. So we can, you know, get like a tomographic view of the anatomy and also assess flow anywhere within the volume. And this technique is becoming more widely used, but it was quite robustly used at Stanford Children's. This is just an example of a patient with repaired tetralogy of Fallot who had a ferromoxetol enhanced 4D flow MRI. And you can see that using one volumetric acquisition, we can, you know, scroll through just like a CT scan with very high resolution and measure flow and function. So all the things with a very usually less than 10-minute acquisition. But 4D flow is complicated. There's 3 major steps. One is the acquisition itself, which is, you know, volumetric acquisition. Usually with current kind of acceleration techniques can be usually under like 10 minutes, around 8 minutes. But if you want more detail, it might be longer. If it's, you know, if you want a kind of a rough one, it could be shorter, but it still takes a lot of time. Another issue with 4D flow is, again, we want the measurements to be accurate in terms of do they reflect the underlying physiology. And there are a lot of sources of error with 4D flow. So there's various pre-processing steps that take a lot of computational time and complexity to perform accurately. And finally is the visualization step. And there's some nice software packages for that now. These were a couple of, again, projects in Shreyas's lab related to 4D flow. One was doing phase, what's known as phase unwrapping. Essentially, you know, when we prescribe a 4D flow sequence, we set the Vanck parameter in all 3 planes. And the Vanck is essentially the maximum velocity, which if you exceed that within the volume, you'll get an artifact known as aliasing. We'd like to keep the Vanck as low as possible to have greater dynamic range and, you know, be able to detect low flow. However, if we set the Vanck too low, we'll get a lot of aliasing artifact. This is a cine image, basically cycling through very low Vancks. This is the descending aorta, and you can see a lot of aliasing artifact. Instead of this nice black flow, we're getting this kind of jagged, like white mixed flow. So using traditional Laplacian unwrapping technique, we were able to reduce some of the aliasing a bit, and then using the deep learning approach to unwrapping, and I won't go into the details, it's performed better than the Laplacian, which was the gold standard. Another nice paper that came out recently from Albert Hischau's group in conjunction with Stanford was basically using deep learning to automatically correct some of those pre-processing error steps I mentioned. This is phase error correction. This is more of a post-processing step that is done manually through the software package. Traditionally, you kind of have to draw a region of interest, what is like the true flow and what isn't, and take out the static tissue. So again, using deep learning AI techniques, investigators were able to do this phase error correction nearly automatically. So in summary, I hope I've highlighted for you kind of the myriad of opportunities to improve reconstruction in pediatric cardiac MRI, but really any imaging modality or application for that matter, using AI principles. And, we, kind of no longer have those traditional trade-offs, and we can increase speed or increase image quality, or sometimes, even do both at the same time without sacrificing anything. And although these, models take training data and time to train, once they're trained, they can be, rapidly deployed in real time. One issue that comes up is it's probably prudent to have, multi-center validation of some of these algorithms with large cohorts, but that can be challenging, and even more so in children. However, as we've shown in our work at Stanford Children's, when the models are kind of rooted in physical principles like the deep learning cine I mentioned, they can be effective on a wide variety of types of patients, despite relatively small training data sets. And I think in the future, for this to be widely applicable to the majority of practices, I'd like to see vendors come out with kind of this simplistic push button approach, so that this can be more accessible, to all types of institutions. And I think we're just starting to see that now. Thank you very much.
Great. Thank you so much, Evan. That was a great presentation. I think for the sake of time, we'll hold a couple of the questions that have come in towards the end for the panel session. And so now we'll move from the East Coast of the US over to Europe. And Sergios, please take it away.
Thank you, Shraz. Thanks for the invitation. In my talk, I will focus on post-processing of medical images in the pediatric domain, and specifically segmentation. And the question is, are children just small adults? So because that's a complex topic, I thought I would ask an artificial intelligence to help me. And you might have heard of ChatGPT, this new very powerful language model. And I just straightforwardly asked, are kids just small adults? And the summary, the bottom line was, yeah, while kids may share some similarity to adults, they are not simply small adults. So this gave me some motivation to continue with preparing this presentation. And as you've seen in the previous talks and also throughout the conference, there are many very impressive applications of machine learning in medical imaging research. And there are many papers summarizing these applications. I've chosen this image just to show you some random examples, and also to show you that most of these examples include the detection and outlining of structures. So here the prostate, for example, some brain lesions, bronchial trees, and this is called segmentation. So segmentation, as I will show later, is one very important pre-processing step before you can perform any other kind of analysis of medical images. So that's why I will also focus on segmentation as this crucial step in medical image analysis. But okay, in research, machine learning is very impressive. How about the clinical situation? If you look at the PubMed hits on machine learning and radiology, you see an exponential growth over the past years. And this is, I think, what we all see also in conferences and in the overall topics that are discussed at the moment in radiology. But if you add the term pediatric to it, it becomes rather disappointing. It's slowly growing, and this has also to do with the work of my colleagues that have shown their results today. But still, it's rather underrepresented. And if you go to the actual clinical applications, again, there's a very nice resource provided by the American College of Radiology, looking at FDA-cleared medical products that use machine learning for medical image analysis. And currently, there are about 200 products for adults. And here, again, you have something like an exponential growth. But what about pediatric applications? One example for segmentation tasks, as you've seen before, is cardiac image segmentation. And this is such an important and successful application because it takes very long to do manually, and it's very simple to interpret the results and correct results if errors are made. So that's why this has found its way to the clinical application. And if you look at this product closely and look at what they write about the indications, you see that actually this is not intended for children, but rather intended for an adult population. And this is something that you will see in many of these products. And if you then go back to this resource that I've shown you before and think, okay, how about pediatric applications? And it's great that they have this distinction here between adult and pediatric applications. You can for yourself have an estimate how many applications are actually cleared for pediatric use. And I think you would all overestimate the number. It's actually 6 applications, which is rather disappointing. This does not mean that the adult applications do not work in a pediatric population, but it means that the companies do not really evaluate and validate these applications in a way that they can guarantee their good function and their validity in a pediatric population. All right. So my question was then, how do I continue this talk if there's so little information? First of all, of course, let's sum up why segmentation is important before I can explain what I've done for this talk. At first, segmentation is a very important step for any other kind of medical image analysis. For example, if you want to measure the volume, for example, of the heart or the liver, you want to know where the liver is or the heart and to separate it from all other tissues. You may want to extract other features then from the segmentation volume, for example, the signal intensity, or you want to use this volume to plan a therapy. And there's also a reason why segmentation is so successful as an AI topic. And this is, as I've shown for cardiac segmentation, it takes humans really a lot of time to do this in a 3D medical image volume. So if you use an algorithm that does this for you, you're quite happy, and you can easily correct segmentations if they're wrong and interpret results and find errors there. So that's why segmentation is also used in clinical practice already, in contrast to maybe many other research applications for machine learning. And also before I go on, I would to shortly explain how machine learning models are trained for segmentation tasks. And what is done usually is that someone sits down, an expert, and needs to manually outline usually dozens to hundreds of target organs or target structures. And then a machine learning algorithm, a neural network, is trained on these ground truth labels to learn how to outline these structures. And at test time, when you apply these algorithms, you input an image without the label, and the algorithm knows how to, in this case, segment the liver and the spleen. Very importantly here, these algorithms usually can only learn what they see in the training data. So for example, here, if you have MRI data for training, it's highly likely that this will not work on CT data. Okay, so I asked ChatGPT again to help me a little bit. So what does this AI think? Would a machine learning model trained on adult data work in a pediatric population? Again, the bottom line was, well, it may be necessary to train a new model specifically on pediatric data. So I thought, okay, that's what I'll do. But before I do that, I asked GPT whether it could prepare my slides for the talk, but unfortunately, it refused. So let's start with the first experiment I performed in order to shed some light on these questions. Are children just small adults? And this first application is organ segmentation on computed tomography. To put it in some context, organ segmentation on computed tomography works quite well in adults because CT is a very robust and quantitative imaging modality, which helps neural networks a lot. So this is a CT scan of a 4-year-old boy, and I used an in-house organ segmentation neural network to produce labels, segmentations of organs. And this network was trained on adults, and this is the initial result. You see that the algorithm has a rough idea where the liver and the brain might be, and where the spine might be, or the skeleton overall, but actually it's a fail, I would say. So you cannot use this. And then I thought, okay, are children actually small adults? And what you can do in deep learning is something called data augmentation. So you can change the training data in order to reflect potential changes in data that you will see also at test time. So here I just reduced the size of the training data during training in a subcohort, and thought, okay, this might improve the results, because the idea is that anatomy is similar between adults and children. Of course, proportions are different, but the organs are the same and the general topology is the same. And after having done this, actually, what the results look like is this. And I would say this is a very, very good segmentation of all these organs. You see the brain segmented, the skeleton, the lungs, the liver, even the transplanted kidney is recognized correctly. So I would say in this case, when it's about healthy anatomy or normal anatomy, children may be just small adults. So this gives us hope that for many applications, you can use algorithms that are trained on adults and with slight modifications apply them to children, for example, as is done nowadays, I would say, for cardiac segmentation. But there are other potential applications that are more complex than that. And we're in a medical domain, so children that we examine are ill, so they have some pathology. And so the next application I wanted to focus on is tumor segmentation in PET-CT data. So specifically here on FDG PET data. This is a complex modality which involves CT and PET. In PET imaging, you can see the metabolic activity of tumors. And we have trained an algorithm here in a large adult population, and you can see how in blue the ground truth segmentation performed by a specialist is practically identical to the result of the neural network that was trained on this population. So I did the same as before. This is the same patient now, but the PET component of the PET-CT examination. And you see that in this patient, you see disease, metabolically active disease in a large portion of the anatomy. And again, if you apply the adult algorithm, the lesions that are segmented do not really reflect the entire tumor load. So large parts of the abdominal masses are missed. And I again try to do the same post-processing as before. So I performed some data augmentation on the adult training data and looked at the results. And again, you can see a great improvement in the delineation of the lesions. But in this case, details matter much more compared to the normal anatomy, because children do not only have different anatomy than adults, so they're smaller, but they have also different tumors, different pathologies, and also different physiology. So in this case, as this tracer shows metabolic activity, there are certain aspects of pediatric PET that are in principle different than in adults. For example, children have very often brown adipose tissue. This is a tissue, often in the neck area, that has an uptake of this tracer and PET. And you can see that there's a false positive segmentation of brown adipose tissue in the neck region, also of the vocal cords in this case. Also, the injection site shows false positive segmentations, and the urinary bladder adjacent to tumor has a false positive segmentation in this case. So this shows you that in the case of pathologies that are specific to children, or physiology and function that is specific to children, we cannot just take adult training data and perform apply algorithms to children. So what have we learned from the literature that is out there and the experiments I've performed for this talk? I think the main message is that machine learning algorithms that are trained on adult data cannot be directly applied to pediatric images in the general case, unless for some simple applications like organ segmentation, as I've shown, there are ways to perform post-processing and data augmentation that enables also good performance on pediatric data. But also in these cases, it wouldn't be so difficult to collect actual pediatric training data, which should be done, I think. But most importantly, for most advanced applications, especially in pathologies and children-specific pathologies and functional assessments, it is absolutely necessary to have specific algorithms that are trained and validated in a pediatric population. So I think there are three aspects that need to be taken care of. First of all, training data and collection of training data is a very important point. And similar to other data, pediatric data are not that abundant. So it's more difficult to collect pediatric training data, but still there are, I would say, thousands and millions of pediatric imaging studies out there. So it's not a principal problem. It's just that one needs to think about this, and also companies should think about this. The second aspect is that, of course, machine learning methodology can help us to translate between different populations, not only children and adults, but also the elderly, for example. And there are techniques for so-called transfer learning or domain generalization, where machine learning models can be used and their scope can be extended to different applications. So these methodological advances could also be applied to help with machine learning applications in pediatric radiology. And finally, for us in a clinical setting, it would be very helpful to actually get FDA clearance also for our pediatric patients. And this is not that hard to do. It doesn't involve actual experiments, actual studies with children, for example, as you need to do for drug development. It's all a virtual study, so to say, as I've done today. So you only need to work on data, which makes things much, much easier. And with that, I'm at the end of my presentation, and I would like to thank you.
Thank you so much, Sergius. That was a great presentation. And thanks again to all of our speakers for outstanding presentations. There are a couple of questions that I think we can open up to everybody here, all of the speakers here. So one of the questions that's come through is, are there future applications that are for using AI that have not yet been developed that would require raw case-based data, raw imaging data? And so would there be value to storing this data coming off of the scanner, the raw data coming off of scanners?
Yeah, maybe I can chime in on that one. I think absolutely. I think that there is value in that, and I think Evan has shown really nicely the value of having raw case-based data, and then comparing it. It gives you this ability to retrospectively undersample and then really train your algorithms. And I think one of the things that's also quite interesting is that I think, as Evan showed, things that even were trained using some adult examples actually perform pretty well in kids, and that's because you're exploiting some of the underlying physics that's going on. But I think as we get to more and more advanced applications, we probably will begin to see things where even some of the underlying constraints that we tend to hold are similar between kids and adults start to fall through. I think it's not something that will be completely imminent to us in the short term, but as we get longer and longer term, it will be there. So I think certainly there is a role to and great value that we've had in our research group of storing raw case-based data. And I think as we get more and more advanced, probably exploiting correlations in a case base that may be specific to children. You know, I don't think anyone's really gotten to that point yet, but I can imagine that one day we will get.
Sergius, is there an analog to that? Let's say, like in the PET realm, you showed some PET CT results, and you know, would there be value there as well?
Yes, of course. I think the images that we look at are only, you know, a summary of the raw data that we have, and a summary that enables us humans to look at data, because we cannot deal with the raw data. So my take on this is that, of course, we should, if possible, if we have the storage, store as much you know, raw data as possible, especially also in PET, where the direction goes towards faster and low dose PET, where you want to avoid the radiation exposure for children. And it would be extremely important to have all these previous examinations that have been performed so far in order to develop these tools.
Yeah, one kind of follow-up question to that I was thinking about with Sergio, as you gave that nice presentation, is, you know, we tend to, it's similar to that ACR checkbox. You know, we tend to think like adult versus pediatric, but there's a wide range in pediatric itself, right? And from neonates to teenagers. And do you think we need to, from a pediatric perspective, do you think we need to pay more attention to, you know, the variability within our own, you know, within that 0 to 18 age range, if you want to create those age cutoffs?
Absolutely. I mean, the difference between a 4-year-old and a 60-year-old, I would say, is larger than between a 20 and an 80-year-old in terms of anatomy, physiology, everything. So I think that's very important. And that's why I've chosen a 4-year-old, because choosing a 16-year-old for these kind of applications wouldn't, you know, show the actual message or bring it through. Yeah.
I actually have a little bit of a follow-on question in that, you know, you took this interesting approach of basically augmenting your training data by scaling down images that you had. You know, an alternative that you could have done is said, okay, well, on a particular case where I want to run inference, why don't I scale that up, run it through the model, get a segmentation, then scale that down? You know, is there advantages to one way or the other of handling this type of problem?
I think it's a little bit different, actually, performing it on the test case, because during training, you will still see the variability of anatomy in the downscaled version, while when upscaling this specific patient, it might, that's just my guess, it might still be that the different proportions of you know, the head being bigger in a child relatively to the body may give you different results, but in principle they should at least improve the results, especially for, if you look at single organs like the heart. I would say a scaled up pediatric heart is almost an adult heart.
Excellent. Another question that's come in is, are there efforts at creating standards for AI and ML enabled imaging that is coming from societies or governing bodies? So what's the activity in that sphere?
Yeah, so I'm actually you know, on the informatics committee for the Pediatric Society for Pediatric Radiology. So we you know, have had started some work into that. I would say, you know, again, as Sergio said, had touched upon, you know, and you as well, Shreyas, you know, pediatrics is a relatively underserved community. And I think a lot of these algorithms that are coming out are sort of developed by the vendors, and then we don't have a lot of say. You know, we don't have like that much say in terms of like what the, you know, because they do the development and we're like, well, we like this one, but we don't like this one, but it's not exactly what we would like. So I think, there are some efforts into that. We're doing it at a small level with the Pediatric Radiology Society, but I think people in general need to be more, proactive about that. The ACR is definitely engaged in that as well, and be interested to hear other people's thoughts.
Yeah, one thing that I think is really interesting about this is that I find a lot of the efforts that Evan has done, and I've been involved in some committees also, is really around validation. But we haven't, I think, exploited the scientific knowledge to determine what within processes of algorithm development or creation are there best practices that need to be implemented. One thing relatively simple thing you can think about is in reconstruction, does data consistency need to be enforced? I mean, you can ask that as an open question at a scientific meeting in MRI and inside a riot. But I think those types of questions I think also are actually quite interesting, and I think there's definitely a role from the scientific community that's doing research in AI and radiology to chime in and say, what are the best practices on the development side that you should look for to really ensure that something has been formulated in a proper way, as opposed to having some validation, which obviously also needs to be done. But I think that it's more than just validation.
Sergius, do you feel that there's some differences in the European approach towards standards or regulatory practice relative to the United States?
Yeah, I feel that the societies and the bodies that decide these things in Europe, I don't know exactly how it's in the US, do not really understand yet how to deal with these questions, because, to be honest, also the scientific community, as Ali pointed out, do not really know how to deal with it. But I would say we need some simple guidelines that everybody can agree on. For example, it's a good chance to say you need to include children, your product to work on children, if this is, does only include collecting data and validating and training on this data. Because if we don't do it now, then we might miss a chance to have it in every product that is out there.
Great. One question that I have for everybody is in the various areas that you talked about, for instance, Ali, some of the automated scanning, or Evan in the reconstruction space, or Sergios in the image segmentation space. How competitive is the industry landscape in those areas? So what's the degree of activity these days?
So if I can answer from my perspective, I think the reconstruction question is dealt with from the scanner vendors, so mostly. So their competition is combined with competition on a hardware level, mostly, I would say. But regarding especially automated diagnostics, which very often includes segmentation tasks, I think there's quite some competition out there. And the difficulty for the vendors is to actually, I would say, get the FDA clearance or the respective clearance in Europe, which is not that easy and has to do with the challenges that we've talked about robustness, about validating the algorithms. So technology gets easier and easier to reproduce. And from my perspective, the vendors with the best data will be the ones who have the best product in the end.
Yeah, I agree.
Yeah, maybe. Go ahead, Kevin. Go ahead.
I mean, I agree. Agree totally with what you're saying. I mean, even just the validation paper that I published, a lot of the reviewer comments were, like how do we know when the model will break, and how will we know if we're seeing artifacts that we've never seen before? How can you be confident in that we're not going to see all these weird things? So again, we did kind of emphasize that it's based in physical principles, et cetera. But I think there's a lot of trepidation still, especially in children, like are these models going to work? How confident we can be that like the images we're reconstructing are of high fidelity. So I think it does take a lot of effort on behalf of the vendors to kind of convince the public that these things actually do work. And I think it is quite competitive increasingly. So
yeah, I think certainly from the sort of automated scanning and scan assistance perspective, it has to be led by the vendors. They have to buy in because it's their hardware platform and their software platform. And I think all of them, all of the major MR vendors really are making efforts in this space. As Sergio's mentioned, it's the development is a little bit slow because they have to get maybe FDA approval on a per application basis, and there's so many different body parts and ways to scan them, et cetera. So I think it is happening, but I do think there's some, as has sort of been a theme throughout this whole session, the underrepresentation of pediatrics. And, we had an abstract at ISMRM basically showing that, these types of models that prescribe cardiac scan planes work quite well in normal anatomy. But if you have a patient who happens to walk in off the street who has a congenital abnormality, or a patient has a known congenital abnormality, and we have many of in our children's hospital, of course, that actually these things, they break down, and they break down quite spectacularly. And one of the dialogues that we had at that time was, there's no confidence associated with the model's inference, right? So it says this is how you get a 4-chamber view, but it doesn't say, oh, and I'm very confident this is a 4-chamber view, or I'm just, this is data that's way outside of my training distribution, and I'm not very confident. And so I think there's a lot of there's a lot of traps that really are in this for the pediatric population, and I think especially from the scan assistance side, where scanning children is so different than scanning adults, I think we're gonna have to be really careful about how these things get rolled out and implemented to make sure that they don't get misused.
Excellent. One of the other questions that's come in is that, as opposed to the pediatric population, are there benefits to applications in AI that would benefit rural populations, which may also be underserved?
If I may answer, so I think all applications of AI, if they work, would make imaging faster, cheaper, perhaps also hardware faster and cheaper. So this already would give better access to a rural population, and also you might not require so much expertise by a radiologist who's in a rural area to be a specialist in all the details of the disease, but who may get some input by a deep learning model. So I'd say this is one of the perhaps most important applications of machine learning to bring medicine to not only rural areas, but also to other countries, other continents.
Yeah, I would just second that from my perspective. I mean, I think the cardiac scanning is a great example of, you're in a rural area, you may have one MRI tech, if that, and this assistance is very valuable. But I will say, I think, we need some help from the vendor side on this. There is a trend, for the few AI products, or for the AI products that have been incorporated, they tend to be incorporated on the newest hardware, on the newest software. And I think there's work to be done if you want these things to really touch those rural, underserved populations. Either you take a trickle-down approach and you really wait, or we have to really emphasize to the vendors that, a scanner that's older, that has an install date, that's been sitting out there for 15 years, actually does need these software products as well, maybe more than, the shiny new scanner that we have at Stanford or Harvard or wherever it may be.
Yeah, and I mean, I think the future of medicine really is trying to bring high quality care, close to where patients live. My current practice, we have not only our main academic teaching hospital, but I'm reading scans from I'm in Massachusetts and New Hampshire and on Martha's Vineyard, so like if these scans are done under the, kind of enterprise of our institution, we want to maintain high quality standards so that, a patient doesn't have to take a boat, over to the Boston in order to get a good scan. So, so I think AI really can help, improve access and bring care closer to home that they could get in a large academic center.
One of the comments that's come in also from the audience is that one person is looking at rural PET imaging, particularly for United States veterans. And they're looking at using AI-enabled technology to denoise these PET images with the idea of really shortening acquisition beds and thereby enhancing throughput. So if you have a limited amount of capacity, say just one PET scanner, you may be able to better serve a larger population through some of these types of technologies.
Yeah, I think great things are happening in the PET-CT area these days. You have the introduction of the total body scanners, which already cut the examination times by 90%. And then you have on top the AI reconstruction. So PET-CT actually nowadays could be as fast as CT, or no, not much slower. So this completely changes accessibility and usability of this modality. So that's quite exciting, I would say.
Excellent. One of the things I'm wondering is for the various types of applications that each of you has talked about, you sort of focused on one particular modality, but how easy is it in that particular area that you're looking at, whether it's segmentation or scan prescription or image recon, how easy is it to take what you've built and translate it to another modality, like say, ultrasound or, something that we haven't really talked about?
So I think that this is the big weakness of neural network-based machine learning at the moment, that transferring knowledge, let's say, from one domain to a different domain is very, very difficult. And this is because these algorithms tend to be extremely efficient in using the available information to perform a task. So for example, in CT, the algorithm will use the fact that CT has quantitative values, has always the same contrast or mostly the same contrast. So if you give a CT trained algorithm, if you give to it MR images, it will not have these clues and it will completely fail. And within MRI, you have different contrasts, different sequences. So from experience, it's very difficult to translate algorithms. So this is, I would say, one of the most difficult challenges to overcome until we can really use algorithms in a widespread manner in the hospital, actually.
Yeah, I think certainly from the scan prescription and assistance type of thing, it's very similar. I think the systems that we've built are very MRI specific, although the overall concept is something that could potentially be, extrapolated to CT to automatically identify how much of the chest should you scan, et cetera.
Right. Yeah, no, I mean, I agree. Similarly, it has to be tailored to the specific application, but, the principles in terms of reconstructing, higher quality CT or ultrasound, there's like kind of a similar principle to all of them, at least.
So we have one final question as our time is running short. So this one is asking, with the increase in AI technology in radiology, will there be a reduction in the human touch in patient care?
To make it short, I think there will be an increase in the human touch, but I don't know what the others think, because we will have more time.
Yeah, no, I totally agree. And like, for example, like what Sergio was showing, even if you can't segment the tumors perfectly, like maybe that 30 minutes that you would take manually segmenting these tumors on a PET scan, you could use that time to, consult with clinicians or talk to patients, so even if these models are not perfect, it's sort of better than us like through it, and it opens up more time to do other things, or scan more patients, have more access. So I think it can only help us.
Yeah, I think our experience has been actually that, as the technologists, for example, who interact with the patients more than the radiologists do by a good amount, right? As they have less tasks to do, punching numbers in, it gives them the ability to have more time to coach the patients, talk to the patients, and comfort the patients. So.
Perfect. Well, I want to again thank everybody in the audience for joining us, and thank each of our speakers for a wonderful discussion and wonderful presentations. Thank you very much.
Thank you. Yeah.
Thank you.
Thanks so much to everyone.